Hi, how are you?
Good. How's it going, guys?
That's going.
It's going.
Single most difficult thing for me in this world right now is calling you Dr. Tran.
Is that right? I can think of harder things.
I mean, considering the scope of what we're facing as a society, I'll take that. That's one of my biggest problems.
Yeah.
How's this week been for you?
It's been okay. This week is our vacation week. So we
Oh.
were supposed to be in Orlando, and so spending a lot of time with the kids was great this week.
Okay, I have a question. So when you're on duty and you back with the kids, do you have to self-isolate?
No. So when we're on call, and work in the hospital on call, yes, we should self-isolate. So in fact, those of us who are on call now and in the last month or so have actually, there's a hotel that UCSD has for us. So the attendings or the residence fellows would go to the hotel and stay in the hotel and isolate away from their families. That way, while they're on call. For those of us who do just clinic for the time being, because I haven't been on call, visited the ICU from time to time and all that, but I haven't seen a COVID patient in the last 2-3 weeks, and so I don't need to self-isolate.
Nice. Well,
So when does the transplant team going to send me my edible arrangement for canceling our trip to California?
You keep waiting for that.
Waiting. I keep checking every time I see a truck drive by. I was like, any moment now. Because you heard how that happened, right?
What's that?
Well, we were supposed to go out there from March 25th through the April 4th.
Or even in Vegas, right? We have a lot of patients in Vegas. We've done a lot of telehealth as well too. Have you guys done that yet with our team, telehealth?
no. So
Okay.
I was gonna get into that. So we do have a lot of people like that we care for, that we're care managers for, that have started using telehealth for their appointments. I haven't personally used it yet because I was supposed to come to clinic in July, so I'm kind of holding off.
Yeah.
But for the individuals that do need to go to a doctor or do need to keep up with their clinics, whatever that clinic may be, I mean, do you like telehealth? Have you had good success with it? What's it like?
Yeah, plus minus. I think that telehealth is a wonderful tool for us. Obviously, we can't do everything that we want to do in the setting of a clinical visit in telehealth. And first off, it has to depend on workflow. If one were to be able to have the workflow, it's so much easier, obviously, to have for a transplant patient, so much easier to have a pharmacist come in, a coordinator come in, and a dietitian come in, and then the physician comes in, and let alone we hadn't mentioned anything about a fellow or resident either, right? So when one is trying to coordinate that with telehealth, it gets tougher to be able to do. While all of the team members can join a telehealth meeting, kind of like what we've got with Zoom, then we can have the coordinator start off, and then the dietitian and the pharmacist going back to the coordinator, then the attending. That's what we do with a lot of our patients as well too. That's worked out well. But in a lot of PCP offices, who don't have the faculties of having a multidisciplinary team like a pharmacist and a dietitian that's also in clinic as well too, it could be streamlined potentially. So it's been plus minus for us. It's worked out very well for those who are tech savvy and are able to get online and with the videos. And I think a lot of your clients, it really depends. And it depends on the ability to be able to get a smartphone, to be able to download particular apps and work the smartphone and troubleshoot some video issues.
Right. Yeah. With all of our active clients, our guardianship conservator clients, we do have to find new creative ways of staying in touch with them. Obviously Nathan cannot go into their homes or nursing homes he normally would. Teaching these 85, 82-year-olds how to FaceTime and Zoom is, it's interesting, right? It's been fun. But Okay.
But-
Well,
but
yeah,
we
I had a question about telehealth. You know, somebody was asking me if any of our clients have used them before, and you know, I wanted to know from a doctor's perspective what it was like.
Yeah, we love it. We want to make sure that our patients aren't exposed unnecessarily to the hospital if they don't need to be exposed. And
Okay.
so we're very grateful that we're able to do telehealth. And we're also very grateful for the ability to have others join in the call for telehealth as well too. So from my standpoint, obviously with my specialty, it's a little bit different than other specialties. But we love the ability to be able to do that, because the less amount of exposure that we get as healthcare providers, that decreases our risk to be asymptomatic carriers as well too.
Yeah.
So if I had seen, you know, you guys don't know this, but in San Diego, this was a huge mask policy that we had, right? So prior to this, and I'll tell you a funny story. So Wetterston, you guys know Nick Wetterston. He's you know, one of our fellows, became one of our attendings. 3 weeks ago, he ended up rounding in the hospital, and he was wearing a mask. At that time, we had a no mask policy. That the only time you would mask is that you would interact with a COVID patient or a potential rule out patient. You wear an N95. If you are not sick and you're not going to a transplant room, do not wear a mask. So he was wearing a mask from a transplant room, took it off, went and took another mask on, put it on in transit to Jacobs Hospital. He was cited for that, for wearing a mask in the hospital by one of the nurses in the Jacobs ICU. So he brought that up to me, and that was going to be a I report that I was going to get because I was the quality director. So I brought it up to the chain of command. So I thought it was ridiculous because we're completely ignoring the idea of asymptomatic carriers. So, you know, the hospital was aligning with the CDC at the time, and we had spoken about this last week as well too. There's so many changes that's happening week in and week out. One of the changes is the mask policy, and so the CDC pivoted and made their change, I think, about a week ago. And obviously, it has no bearing. What we experienced at UC San Diego had no bearing on the CDC's decision, but they made that pivot and that change. And I suspect that UCSD, while following CDC, the reason why there were such concerns because there weren't a lot of masks to go around, and they were concerned about the inventory of masks. But if you were to take a look at 3 weeks ago, somebody wearing a mask is cited. Now, today, April 17th, 2020, somebody that's walking, any of the healthcare providers walking in the hospital right now without a mask will be cited. So it's a complete 180, right?
Wow.
So if I had seen a patient, this is going back to your original question, Amanda, is if I had seen a patient in the hospital without a mask 3 weeks ago, and that person was an asymptomatic carrier in the clinic, and they had given it to me, and I'm an asymptomatic carrier, now I'm giving it to my family and anybody that I'm interacting with closely as well too. So decreasing that risk of exposure is very important to the healthcare provider. We don't want to do a physical examination on a patient or expose ourselves to a patient. We don't necessarily need to, if we can get by doing this telehealth visit.
Wow. That kind of leads me into my mask question I got. We can't find masks here. I mean, there's just any masks that are coming into our state, you know, they're going to the hospital, which they should be going to. They're going to healthcare workers, which they should be going to. But, you know, for us, we were lucky enough to get our hands on a couple, but for a lot of our clients, they don't have those needs. And they've been making like homemade masks or bandana masks. How effective are those homemade masks?
So I'll give you a couple examples. So if you wear what the CDC would call scarves or some sort of facial covering, right? You can make masks with, I've seen people make masks through t-shirts, you know, through scarves and other clothing as well too. So I'll give you 3 examples. If that person were to walk into a COVID positive room, okay, that's not going to protect them at all. In a COVID positive room, it's not going to protect them at all. And it's because the virons are very small, and the only mask that really works are the N95s, right? If they were to stand in the corner of the room and the COVID patient is far away, chances are they won't be that exposed, right? It has to be close exposure in terms of the droplet precautions that we have. But that person would not be protected. However, if that person be walking around the hospital and stuff, is somewhat protected. It's pretty good. It's okay. If you're walking around going to the store, you're going to be fine. I think a lot of that too is protecting one another from this asymptomatic carrier. So if one is walking around the mall or walking around the grocery store, I should say, with a scarf or some sort of clothing that's made into a mask, that should suffice for the time being, because you are protecting other people. And also, there's a lot of psychology into this as well too. As one is wearing the mask, you're not touching your face as much. And one of my cousins had told me back in February, wow, I had no idea how often I touch my face. Right when this whole thing started, he started saying, he's an optometrist. He said, wow, throughout the course of the day, I touch my face a lot. I'm more mindful about that now. The masks actually puts a barrier between your hand and your face, so it really puts touching your face. It helps you with that contact.
Even though for me, you guys trained me not to touch my face. After a transplant, I think I went through a huge, even course about touching my face. But still, even 6 years later, I completely forget how much I actually do until I wear a mask, and I'm like, oh my gosh, and I'm not even the average person, so.
I have a question.
But honestly, any mask is better than no mask.
Right. In California, it is recommended that anytime anybody goes out, they ought to be covered.
Even just going out for a walk.
So that's a great question. Going out for a walk, not so much, but in terms of a public arena like a grocery store, they ought to have some sort of facial covering on. I do know, though, that there are cases where some of my friends in LA who have gone for a walk, they've been stopped and they've asked to go ahead and put a mask on. In LA, we haven't had that in San Diego, but that's recommended as well too. That you should have a facial covering. I tried jogging with a mask on; that was way too hard. And now that we take walks with the kids, we put our masks on.
So I have a question, and I don't mean to circle back to the telehealth. I just wanted to get some clarification for our clients who will see this. So with urgent cares, primary care scheduling, emergency room visits, there's usually a set of guidelines in which you kind of, even before this, you would assess, and doctors would speak about like, all right, you injure yourself at home, it's bleeding profusely, you go to the urgent care, not the ER. What types of uses and what's the kind of threshold on what telehealth can actually be used for? Common colds, seasonal allergies?
Absolutely. I think those, and I'll speak in a spectrum of conditions, but I'll also speak to what we see primarily. From our transplant perspective, if we always ask our patients that we would urge them to do telehealth if we can. However, if the patient feels as though they need to see a physician for any reason, we will see the patient. And so it's not an absolute, everybody needs to migrate towards telehealth. It is, if you are comfortable with telehealth, let's do it. But if you're uncomfortable for any reason, technology, living far away and just making a trip here and just wanting to see the doctors or just wanting to see doctors in general, we will see our patients. So in our clinics, at the beginning of our clinic for the first 3 hours or so are inpatient visits. So still face-to-face visits. And we have 3 to 4 face-to-face visits per hour. And then towards the end of the clinic, that's when we do all of our telehealths. And that's when all the providers get together for the next 2-3 hours doing telehealth work. So I think that's one way to look at it. But in terms of symptom specific, anybody that has a fever, anybody that has what potentially could be a viral infection, you've heard of this in the past in terms of fevers and coughs. and malaise. That is to say that you're just feeling kind of blah, not wanting to do anything. The fatigue, well, as well too, i.e. moving about and doing your daily chores, but still feeling very, very tired doing that. Those are very important symptoms that may point us towards COVID or SARS-CoV-2. Additionally, what you've seen in the past week or so, particularly with the ENT group, and this is something I alluded to sometime last week, I believe, which is become a big thing now, is the loss of taste and the loss of smell. If that is a symptom as well too, that's something that is recommended as of this week to talk to a provider about.
So I saw that. Sorry, I saw that. Loss of taste, loss of smell. That we weren't seeing that a few weeks ago. Like, are we now starting to see a whole bunch of new symptoms? Are these new? Have they always been there?
They've always been there, Amanda. We've known about them in Italy as well too. So we've had pretty close contacts with our friends in Italy, so we've known about that. But it wasn't that here when we started seeing these patients, and this goes along with something we talked about in the past as well too. I think we have way more COVID cases or SARS-CoV positive cases in America than the national tally is, right? And that's because of under-testing, but that's also because of some of the weird symptoms that this coronavirus can cause as well too. And this loss of taste and loss of smell is one of those things as well too. And we're going to see more and more of that, and we're identifying that this is really associated with coronavirus. And in addition to that as well too, there are also anecdotal reports that when one has the primary symptom of loss of taste, loss of smell, that it is less of a strong, it is a milder case of coronavirus than compared to obviously the intense shortness of breath and ultimately decompensation.
So just not meaning to cut you off, but that kind of leads me to one of the questions that I do have. So how do you describe to people that you treat or that you care for, are there different strains of this virus, or is it just completely dependent on how it just impacts the person? Because I have heard that. You have your asymptomatic people, you have people that, due to the limited testing that has occurred, but what actually has been done, some people have tested that they already have the antibodies to defend against this virus. Like, what are the factors there? Like, are there different strains in terms of severity, or is it just kind of the I guess the situational exposure that people may have had?
Yeah, I think that's a great question. I think time will tell, but I can tell you what we think. We think that it's the latter. I think that it is just people's response is very different. Why would one person respond one way versus the next, regardless of comorbid conditions and regardless of hypertensive disease, regardless of coronary disease in the past or diabetes? We already know that those patients are at particular risk for a bad response. But so walking it back a little bit too, you have to get into the virus's mind, right? And the virus's mind is what makes the virus happy. A successful virus is a virus that is able to infect. That's all it does. It gets in the body, gets into the cells, starts replicating its RNA, in this case an RNA, and then makes proteins from this, kills the cell, and infects other cells as well too. And what makes a virus happy and successful is the ability to get to the next patient, the ability to hop from one patient to the next, to the next, to the next. This virus is very good at doing that. This virus is very successful and it's very effective. So it doesn't need to mutate, right? So if it doesn't need to mutate, chances are there's a very few amount of strains that are there. So
Howie. Sorry, you're frozen.
yeah, let me see if I can, this may be better, let's see. I may jump you guys onto this side, okay? So can I cut this to jump to the other side?
better at all?
Got it.
Yeah? Okay. I don't know where I left off.
Here, close out this one.
Okay.
There you are.
Perfect. You were talking about people's response to the virus.
Oh, right. So the
different
people's
generations,
response.
you know.
Yeah, people's response to the virus. And one of the things that I got into talking about was what makes the virus happy, right? What makes a successful virus? A successful virus is when a virus comes in, infects the body, infects the cell, and in this case, replicating its own RNA into DNA, proteins, and all that stuff as well too, right? So RNA into proteins in this case. So making proteins, infecting other cells of the lungs, parts of the body as well too, potentially heart as well. And its job, what makes it happy is if it's able to not kill the host, but able to get that host to pass it on to others, okay? And if it's able to pass it on to others, that makes it effective. This virus is very effective. It is able to pass on, be able to be transmitted very easily. So there isn't a need for this virus to mutate, right? We get mutations in viruses because we have immunity to these viruses. And these viruses, by chance, can mutate, and all it takes is one mutation for our immune system not to recognize it, and then all of a sudden that mutated virus is now the predominant virus. This virus doesn't have to do that. This virus is very good because we've never seen this virus before. So it doesn't have to mutate. So I don't think there are a lot of strains out there. And that's why when you listen to some of the NIH and the CDC folks, is that they think that once we have a vaccine or immunity to this, it may last for some time. It may be a situation where we may need to revax ourselves and boost ourselves in the future. But they're pretty confident, fairly confident, because it's such a successful virus that it's likely one type of virus that's doing this, as opposed to a bunch of viruses within the coronavirus subclass that's doing it. So chances are it's probably one predominant virus that's doing this, one strain of its predominant virus, and we're just having very heterotopic, very different responses to this virus.
This might be a bit of a self-defeating question, but I have to ask because I'm so curious. Being in the medical field, how far away do you think we are realistically to having a bit more of an aggressive response, such as a vaccine, something that could put us in a position to return to normal?
Yeah, it usually takes a year and a half to develop a good vaccine, right? Because with a vaccine, the development of the vaccine, fine. But you want to make sure that the vaccine is effective. And in order to have that happen, we do animal studies, and then we do in-human trials and in-human studies, and then we go from there and say, yes, it is safe, let's go ahead and use it and go forward. That process, even though we're working at light speed right now, will probably bring us sometime into the fall, into the next winter. So that's probably when we're going to get a vaccine. So we're pretty far away.
So that leads me into my question perfectly. But first off, I had to join your
Look at that.
represent.
We didn't have to have a member.
Amanda, I had one more follow-up for Howie about this. And the vaccine question comes up because, every day it seems like we're getting new information on how this virus spreads, its capabilities, what to watch out for, how to, just conduct yourself and while you're out and about. But that article about that a tiger from the Bronx Zoo was infected with COVID-19 seems like that was swept under the rug pretty quickly, because I remember one of the headlines saying that it's one of the first instances in a very long while that there was that kind of interspecies infection. Does this virus have the capability of spreading to, tigers, obviously, but our household pets? Could they be carriers of this virus?
Oh, very good question. I don't know if they're respiratory carriers. You know, this tiger business, I think it was in New York, and it
Mhm.
might have been Bronx Zoo. I don't think
Yeah.
it's the, yeah, it might have been the Bronx Zoo, but I don't know much about it to be honest with you. And I think this virus is already proven to jump species. And I think that's where we're at right now. We still believe the way that we believed last week when I shared with you that it would probably came from a bat to an intermediate host to us. And there's a lot of chatter that's going on right now where the sources of this virus, and I don't know. I think we're gonna have to wait for documentaries about this and reports about this as to where this actually came from, because the wet markets in China are saying that they don't sell bats anymore, vis-a-vis because they've had issues with bats with MERS in the Middle East and the original SARS back in 2002. So they don't sell bats and all that stuff as well too. So that's why we believe there's an intermediate host, and we believe that in terms of the sequencing, the RNA sequencing looks very similar to the pangolin, which I think is a small little armadillo type of an animal. But yeah, I think this virus will have it's already shown that capability. Obviously, this particular virus has a tropism or an affinity for us, and the particular area is our lungs, right? Because it has different receptors that it likes that our lungs has, and I can talk about that a little bit later on as well too. But I don't know what to make about the tiger. I don't know why some of the other animals are absolved and not infected in the zoo. And it's tough to keep animals social distancing. I would assume, but yeah, I don't know what to make of that. But this virus can do anything that it wants. It's shown that capability.
Yeah. So we've seen, I think it was yesterday on the news, that some states are now pushing our new release date to May 15th. Do you foresee other states following suit quickly?
Yeah, so this is going back to our discussion last week. I think one of the questions you had asked me is April 30th, May 1st, the right timing for the nation to get
Right.
back? And I think it was, and I still do feel this way. It's premature. I think things change so often that we're putting a time frame out there, which is 2 weeks away. We're putting a time frame out there and saying that we're going to do something by then. And if you were to rewind time 2 weeks ago, we look completely different. So I think that I'm going to allow for us to change a little bit more. But I'll tell you that this mid-May new deadline, this arbitrary deadline, is still very arbitrary. And it really depends, because if we do this the wrong way and we start to see a sudden surge, guess what? Everybody's going to be pushing that back into June and July, right? And you've seen that. You've seen that in Italy. You've seen that in Wuhan. You've seen that in Shanghai. So, and you're starting to see that in South Korea as well too, which is one of the original best models that we had on how to deal with this. So I think we're still fairly premature. I think pushing it back is the right thing to do. I know that just yesterday the government had come up with a 3-tiered system in order to have a liberation of this self-isolation and whatnot too. You have to satisfy 3 tiers within a particular locality, and obviously a place like New York would probably be one of the last places that would come out of all this and be able to commingle again.
It seems, I'm sorry, Amanda, it seems like governments, the CDC, et cetera, it seems like they are, you're able to track that they kind of do this in 2-week increments at any given time. Just as far as when this first started, it was like, oh, we're going to be isolated for 2 weeks. That turned into April 15th around tax time. And then right around this same exact time, they're like, end of April. And now that we've kind of crossed that threshold of that 15-day marker, that's when I've seen states go, the respective governors, May 15th.
Yeah.
It seems like, they don't want to give it to people all at once to say, realistically, you're probably looking at fall.
Yeah.
but some sense of hope in the sense maybe this may end, maybe it's not, but realistically, you know, with other states, I think 6 states had already opted to May 15th.
Mm-hmm.
And usually the trend is every state kind of thereafter follows.
That's right.
And
And
I mean,
I think that, you know,
being immune compromised myself, like I know I'm not going anywhere for a long time. And a lot of our clients are in the same boat. You know, they're either immune compromised, their loved one is. Now, in the instance of like Nathan and I, he goes out to the store, he goes out to the pharmacy, he goes, you know, he does those things. What are the precautions that people like me with immune compromised systems, what are the precautions that their loved ones should be taking when they come back home from their outing?
Yeah, that's a good question. And I'll tell you what we do in the hospital, and I'll tell you what's sort of recommended from a public standpoint as well too. The precautions that Nathan should take and probably is already taking is masks. And you know, I actually go out into the supermarket and I do all the shopping for us, because and that's by virtue of me going to the hospital and working in clinics, all that as well too. So we just want one person to be the person, and same thing as your family. And what I do is that when I go to the grocery store, I have my gloves on, but I have 3 sets of gloves, and I have just one mask. So with the 3 sets of gloves that I have, and I have Purell in my car. So what I would do is to get out there, put on my first set of gloves when I do my shopping, and anything that I touch and all that stuff that I put into my cart, I'm very mindful that I'm not, you know, doing anything else with those sets of gloves. I take that set of gloves off when I'm ready to pay. So once I load it onto the conveyor belt and it's running through the cash registry, I take that set of gloves off, and that's going in the trash can. Then I operate my phone or whatever and my credit card. I actually have all my information on my phone, so I pay via phone. So there's complete no contact whatsoever. And I don't bring any of my home bags with me. This is going to be bagged in the grocery store. And in California, we have to pay extra for a plastic bag. Some places have cut that off, and they said, you know, whatever amount of bags that you guys want, let's just get through this pandemic. So next, I put in my second set of gloves, and then I load all of the food into the trunk, and then I throw that away. And then I get in the car, Purell, and then drive home. And my third set, I bring all the food into the garage or the kitchen, wherever one wants to do it, to kind of disinfect stuff. Now, it's interesting. I think that CDC came out this morning and said that you don't need to do that. You don't need to disinfect your groceries and all that stuff too. But working in the health field, I feel that it's important that I do that, and I continue to do that. And my kids see me do that as well too, just taking this very serious. So what we would do is just take the groceries, take them out with all my gloves and everything, tear them off, and then I'll just spray down all this stuff, wash all the vegetables. And then after it's sprayed down, then we'll go ahead and unpack and put it in the refrigerator. I take a shower, and then we're clean. At home, we're completely clean. It's easier for me in my mind because I've been brought up in medicine, and we have surgical techniques that are sterile techniques, right? So when I go in and I do procedures, I have a sterile technique. So in my mind, there are compartments of what ought to happen outside of the procedure room and what should happen inside the procedure room. In my mind, it's easy to make that compartmentalization. It's tougher for those of us who haven't had that training. So I think it's important to try to keep that in mind. It sounds a little crazy for me to have 3 sets of gloves, but that works for me. Whatever works for you, do it. If you have a Purell bottle that you're bringing to the grocery store, you don't need gloves. Just keep on Purelling and making sure that your hands are completely clean, right? So the 3 glove system works for me. It's sort of like the 3 outfit system that I shared with you when I go to the hospital. If I'm on call, I have 3 outfits. So that's sort of what works for us. But I applaud you guys for doing that. I think it's very important that Nate, out of the 3 of you, Nate is the one that's going out there. Hey, and Nate, I would actually advocate for you, brother. I know of your lung situation, and that's something that I'm concerned about. I want to make sure you're fully, you have something fully covering your face.
I don't go out without an N9. So not because of the pandemic, just naturally, what I do normally for hobbies, cleaning, stuff like that, because, you know, out here in New Mexico, we have the HANA virus. So, you know, we have rodents and stuff, you know, every house is next to a mesa. We have a rodent problem everywhere. Now, granted, you can manage it, etc. But when I'm in the garage or I'm in my shed, laundry room, and I'm cleaning, kicking up dust and stuff, I actually just happen to have a stack of 4 N95 masks that we use and we sterilize and we reuse. I found that right now baking the masks is probably the safest thing. Through 150 for 20 minutes, then the mask is nice and hot so we can reuse them. But I mean, yeah, and that's always the biggest concern for me, is being the to-go-to person. But thankfully, I've had, you know, extensive practice with sterilization and Amanda. So that's what we do. We go shopping. I'm the one who touches the bags, the groceries, until I put them in the car. Second I sit in the car, I don't touch anything. Amanda sprays the Purell into my hands. I lather. And then when we get home, Amanda has, you know, the reusable gloves, the thick rubber latex gloves. She'll take everything out. She'll wash it. The bags that the groceries were in go straight into the trash. So yeah, we have a system, but I think it's important that you touch base on the need for sterilization practices and being aware of what you're touching in the process, because you will have people who have their gloves on, touch the vegetables, touch the bananas, everything, and then go to pay, pull out their wallet with those same gloves, touch their debit card, take off their mask with that glove. Actually, before and even after I Purell, once I get back into the car, I have Amanda grab the back of the mask to take it off of my head, so I'm not directly touching the gloves while the Purell is drying.
I think you're right. I think, you know, this is going to teach us a lot. And one of the things that this pandemic is going to teach us is our own awareness. There's an article about, why do we shake hands? Do we need to shake hands going forward? So I think after we're done with this, and it's not going to be a boom one date we're going to turn on the economy, we're going to turn on the country all over again. And it's going to be a process. And I think we're all going to learn something from this pandemic, unfortunately, but it's going to make us very self-aware.
Oh yeah, I mean, I've given up the habit. Well, you remember, Howie, I usually walk around with a toothpick in my mouth.
Yeah.
Haven't done that since the start of this whole thing, just to have one more excuse to avoid touching my face.
Oh yeah, you know, it's interesting. You're right, because I do remember that. But you know, my son, I don't know if you guys have seen him. He has this trick that he does, and he's able to lick his nose. He's got this long tongue, right? He's able to lick his nose, and people love it because it's so cute when he does it. And as a father and as a mother for Jess, we're like, don't do that, please. Even if people ask you, don't do that. But through this pandemic, we've you know, he's heard enough about this coronavirus that he doesn't do it anymore. So whether it's because of this or because he's getting a little bit older in the last month or two, that he doesn't do it anymore. But it's just self-awareness.
Absolutely.
Yeah, you know, for having gone through so much, and I think I can say this for a lot of our other clients that are immune compromised, is that this isn't as hard on us. I think that it's not as hard on us that have already had to quarantine at some point in our life or have had to take extra safety measures. It's just not as hard. It's still hard, but you know, we have more of an understanding about it.